All right, so today we are here to talk about managing CKD population health in the safety net health setting opportunities to improve quality of care and reduce cardiovascular risk. Here are our learning objectives for today, which I think most of you saw in the information about this webinar in advance. And to get us started, we wanted to just do a quick poll to get to know who is in our audience. So they're going to bring up a couple poll questions so we can learn who you all are. Leave it open for just a minute or two. And I know a lot of you were introducing yourselves in the chat with some of your locations, but we'd love to know kind of which part of the country or migrant stream region do you practice in, as well as your clinical or non-clinical background. And hopefully once people have had a chance to answer, maybe just give it a few more seconds and then we can see the results. All right, this is great to see. So we've got a good mix of clinicians, as well as a number of community health workers. That's great to see. And a good geographic mix. It looks like we're pretty well spread out across the country. That's fantastic. So getting into our program, we're going to start today with a little bit of a background on chronic kidney disease, overviewing some of the complications and challenges associated with kidney disease, as well as some of the health equity challenges that we face at all as well. So chronic kidney disease affects about 15% of our adult population, or about 37 million Americans. However, 90% of those individuals remain undiagnosed and unaware of their condition, including almost half of people who are in or approaching end-stage kidney disease. What's worse is that about 80% of those people who are unaware of their kidney disease status already have evidence in their medical record that shows that they have kidney disease. So they have either an EGFR or a UACR in their medical record that suggests they may have kidney disease, but no CKD diagnosis. This graph here shows the kind of distribution of prevalence of kidney disease across the stages based on surveillance data. And you can see the bulk of patients are in that stage 3 kidney disease. The lighter orange bars that are just coming up on the screen here show the prevalence of people who know that they have kidney disease across those stages. And you can see it's a little bit hard to see just because of how small of a percentage it is, but even in stage 5, we see that about half of people remain undiagnosed. Stage 3 there, you see probably the biggest discrepancy between prevalence and awareness. Even though at stage 3, people are likely to have evidence of kidney disease and are already showing the kidney disease is already showing impacts in terms of their use of healthcare utilization, their hospitalizations, their risk of mortality, and the complications of kidney disease. This purple bar that just came up on the screen, that demonstrates the cardiovascular risk associated with kidney disease. So most people, when they hear CKD, they think end-stage kidney disease, dialysis, transplant, kidney failure. And absolutely, those are important and problematic complications of kidney disease and something that we absolutely want to avoid. And many clinicians, health systems, quality improvement efforts are focused on those stage 4 and stage 5 patients and trying to manage their progression to end-stage kidney disease. But what a lot of people don't understand or don't recognize right away is that kidney disease is also a cardiovascular risk factor. And kidney disease significantly increases your risk for cardiovascular events, even in those early stages, well before someone is in any danger of needing dialysis or needing a kidney transplant. And that's really one of the problems that NKF is trying to solve. We're trying to increase the awareness of this more immediate impact of kidney disease, which is that cardiovascular risk. And so this purple line, again, shows that risk of cardiovascular events as kidney disease progresses. And you can see that that starts to rise well before someone is in stage 5 kidney disease where they need dialysis or a transplant. Some risk factors for kidney disease. In most cases, CKD does not, chronic illnesses like kidney disease don't occur in isolation. And many of our patients with kidney disease also have other chronic conditions like diabetes and high blood pressure, as well as older age, obesity, family history, and cardiovascular disease are other risk factors, as well as a history of something called acute kidney injury. So if you're working with any patients that have any of these factors on the screen, they are at elevated risk for kidney disease, and probably their kidney function should be being assessed on a regular basis. Oops, I didn't mean to do that. We also sometimes refer to kidney disease as a disease multiplier, because when someone has kidney disease alongside other chronic conditions like diabetes or hypertension, it complicates and it makes those conditions worse and those outcomes worse. So we often see these conditions occurring hand in hand, and the underlying kidney disease is often complicating the treatment or the management of those other chronic conditions. Again, that's just another reason why we really advocate for earlier testing, earlier screening and diagnosis of kidney disease. I've made this point a few times, but CKD is a cardiovascular risk factor. And this graphic here comes from a publication put out by the American Heart Association last year that outlined something called cardio-kidney metabolic syndrome, which is really just describes what I just spoke of sort of the interrelationship between these multiple chronic conditions like diabetes, cardiovascular disease, and kidney disease, kind of a co-occurring hand in hand. And they do call out CKD as an early metabolic risk factor for cardiovascular outcomes, which is something that NKF has been saying for a long time. And we're really grateful that other organizations like the American Heart Association are also calling this out as well, because recognizing the impact of chronic kidney disease on cardiovascular health, as I stated earlier, really helps to reiterate the urgency to act around kidney disease. We're not just worried about a problem that's 5 or 10 years down the road when we're thinking about kidney failure, but we're worried about some of these more immediate impacts around cardiovascular events. The American Heart Association also acknowledged an important piece of managing cardio-kidney metabolic syndrome, which is another thing that NKF has been speaking to for a long time, which is the importance of screening for kidney disease with 2 recommended screening tests: urine to albumin creatinine ratio, or microalbumin, as some clinicians might be familiar with it, with that name, as well as estimated glomerular filtration rate, or EGFR, which I will speak to a little bit more in some future slides. For now, I'm going to turn it over to Kira to talk a little bit more about health equity and health disparities in kidney disease.
Thank you, Caitlin. So when we're talking about the prevalence of an impact of a chronic disease like kidney disease, we would be remiss if we didn't review the data that depicts how CKD is experienced differently in varying communities. Specifically, the inequities that exist through our kidney patient journey that leads to these outcomes that you see displayed on the screen here. These are the facts that should drive intervention, programming, and policy to truly address the root cause and meet people where they are. And so you may have seen some of these stats before, but Black Americans make up 13% of the US population, but represent 33% of end-stage kidney disease population. They are also 3.8 times more likely to develop end-stage kidney disease. Native Americans are 2.3 times more likely to develop end-stage kidney disease. Hispanic Americans are 2 times more likely to develop end-stage kidney disease. And Asian Americans are 1.4 times more likely to develop end-stage kidney disease. And this is all compared to white Americans. And so overall, communities of color, and you can advance to the next slide, or the next, yeah, thank you. Overall, communities of color are just less likely to be tested for CKD, receive timely referral to nephrology, utilize home dialysis, employ peritoneal dialysis, receive a fistula, be identified as a candidate for transplant, be referred for transplant evaluation, less likely to be placed on a waiting list or secure a living donor, and less likely to receive a kidney transplant. And although that was a mouthful and that was a very long list, this is not an extensive list of the challenges that these groups face to receive the quality care they deserve. And you can advance again. And similarly, people living in rural communities experience many of the same issues, in addition to being more likely to be uninsured, have less access to primary care for diagnosing, have less access to kidney specialists to manage care. In rural dialysis facilities, they were less likely to offer home dialysis as an option. And if there are patients in rural patients were more likely to be on home dialysis, that's because they travel to urban dialysis center for their care. And then finally, rural communities also just have a higher risk of mortality when it comes to being on dialysis. And these stats are inclusive of farm workers who are mostly people of color and mostly living in rural communities. 78% of farm workers identified as Hispanic. Among US born farm workers, 32% identified as Hispanic and 10% identify as Indigenous. But I want to be clear that all these aspects of care you see here on this slide are not inherently due to race, but instead a result of social drivers of health that shape health outcomes. And those social drivers or non-medical factors, like the conditions in which people work, live, play, learn, and age, that disproportionately impact communities like farm workers and make the population susceptible to adverse health trajectory. Next slide. In looking at the progression of CKD, like many other chronic conditions or chronic diseases, it is associated with significant structural barriers that contribute to poor health outcomes. So this flow chart depicts just that and highlights the structures that surround and influence socioeconomic deprivation and the role that plays in the development of obesity, diabetes, hypertension, cardiovascular disease, which in turn can contribute to a diagnosis of chronic kidney disease. And I just can't stress this enough that biology really plays a minor role in the elevated risk of CKD. More so, it is that social and institutional inequities that fuel this risk. Farm workers represent some of the most socially and economically disadvantaged people in the U.S. And you can stay on that past slide. They represent some of the most socially and economically disadvantaged people in the U.S. And 20% of agricultural worker families and family income levels are below the national poverty guideline. And discrimination has a trickle-down effect on what types of jobs that are available to certain populations and the conditions and the environment people experience while working. It also impacts where people can live, keeping in mind that 30% of farm workers reported living in crowded dwelling. It also affects health insurance status, and that's knowing that employment in the US is really tethered to health insurance. It also has impacts on low literacy levels, cultural barriers, frequent mobility, and its impact on access to social services and cost-effective primary health care. And all of these things are health equity concerns facing agricultural workers. While individual behavior can have influence on health outcomes, we also see the importance of addressing the root cause, like system barriers to optimal health that these communities face. Next slide. And as you are maybe already aware, farm workers are vastly responsible for getting food from the field to plates across the United States and the world at large. And the US food and agricultural system heavily depends on manual labor of these hard workers, yet their unique health and safety needs are often overlooked. And chronic disease can also have an emotional, physical, and economic toll on farm workers, reducing their earnings and making it more difficult to pay for care, medicine, and health insurance. When families or friends take on informal caregiver responsibility, they may also experience reduced working hours or increased absenteeism, which can lead to lost productivity and wages, and some even forego needed care to continue work. The burden of chronic disease in the US is costly, according to the CDC. 90% of the annual healthcare expenditure is attributed to managing and treating chronic disease. Additionally, according to the Bureau of Labor Statistics, it is estimated that workplace injuries and illnesses cost about $39.1 billion a year. And even those data points may be grossly underrepresented by some farm worker populations who choose not to seek health care or report occupational injuries and illnesses for various reasons. In other healthcare settings, there have been a noticeable shift to value-based care arrangements, and organizations are facing unrealized reimbursement opportunities from not managing chronic kidney disease. The average age of farm workers is 41 years old, and 67% are between the ages of 25 and 54. And although CKD is often associated with older adults, 12% of people age 45 to 64 and 6% of people age 18 to 44 have chronic kidney disease. And rates of end-stage kidney disease have risen fast, about 55% of an increase in people between the ages of 45 to 64 over the past decade. And with that increase in prevalence of environmental and lifestyle-associated diseases such as hypertension and diabetes in younger people, there is a potential to see more and more younger people diagnosed with chronic kidney disease. And you'll also notice that many farm workers have diagnosis of obesity, hypertension, and diabetes. Over 24% of people with hypertension have CKD, and little over 40% of people with diabetes have CKD, and which are the risk factors we most associate with chronic kidney disease. You'll also notice that kidney disease is not listed here, but that doesn't necessarily mean that there isn't a concern for this population. Next slide. So farm workers are uniquely positioned because of the environmental and occupational factors to be exposed to non-traditional risk factors that lead to kidney disease, including acute kidney injury. And unlike the common causes of kidney disease typically seen in the US, it moves away from hypertension and diabetes, and instead presents as a result of climate change, heat stress, dehydration, exposure to harmful pesticides, which could also lead to contaminate the water supply. And farm workers may present with acute kidney injury and causes by hydration and long working hours that leads to kidney failure. And these trends were initially noticed in Central and South America among young workers in sugarcane fields. However, it has made its way to the United States and is being termed in the literature as an epidemic. Next slide. So before we transition to the next section, I just want to take a moment to pause and welcome any questions at this time about the information we've shared thus far.
Looking in the chat, there was one question in the Q&A around some of the environmental risk factors that you just spoke about. So I think that person read your mind a little bit, Kira, and got ahead of that question. So hopefully we address that sufficiently for the person who asked that question. Otherwise, I don't see anything else in the chat.
Okay. We will have other opportunities to add questions, and you can feel free to add them into the chat. They'll be monitored as well. Were you going to say something, Caitlin?
Nope, I was going to say the same thing.
Oh, okay. Okay, and so your health centers serve as a population disproportionately affected by CKD. And so now we'll just share some best practices for how you can address and manage CKD in your population. I'll hand it back over to Caitlin to continue on.
Thank you. So as you can see, we're going to start with another poll, just to kind of get, hopefully you've heard from this information, kind of urgency. We've articulated the urgency around kidney disease. So we'd love to understand a little bit how you as clinicians and care team members are feeling about your clinic or your service area's capacity and readiness to manage kidney disease, and maybe what some of those barriers are. We'll give that poll a few minutes. I do see, while people are answering the poll, I do see another question that just came in from Carlos asking about a particular pesticide or chemical that is associated with CKD. I'm not as familiar with the literature to be able to speak to that, but Kira, unless you came across that, otherwise we're happy to bring it back to some of our medical teams and get back to you if there are specific chemicals of concern.
There were some listed. I don't have that committed to memory, but we can definitely get that back, get that information back to you. Thank you for the question.
Perfect. So we'll circle back via email on that one. All right, are we about finished with, you want to see those results for this next poll? All right, so it looks like a good mixture of readiness. For those of you that are in the slightly, somewhat, or not at all ready, hopefully the information that we're about to share will be helpful to move you along. I will also say that NKF is happy to provide additional follow-up resources on an individual basis. And then some of the barriers that we're seeing, looks like knowledge on the medications and treatments, capacity and time barriers, competing priorities, and then patient level social and cultural barriers kind of rise to the top, which is helpful to know. We'll cover some of these things in our next few slides. And we also, again, are happy to connect individually with clinicians and clinics to provide some more tailored resources. So I spoke a little bit about the importance of screening in my earlier slides. So just to get in a little bit more in the weeds around that, there are two tests that are required to identify kidney disease. One is the serum creatinine with eGFR, which is a blood test, and the second is the urine albumin to creatinine ratio, which is, as the name implies, a urine test. Many of you are likely familiar with eGFR, and chances are you have eGFR results for your patients in the medical record, especially if you've gotten a basic metabolic panel or a comprehensive metabolic panel in your patient at all in the last year or a couple of years. But eGFR alone is insufficient to appropriately assess the severity of CKD and the likelihood of its progression. This heat map here shows how clinicians can use both eGFR and UACR to appropriately understand the staging and severity of CKD. A great example is CKD stage 3A. If you're looking at eGFR alone, you might kind of see stage 3A as, only mildly to moderately decreased kidney disease. But depending on what the UACR or the albuminuria results are, that person could be in either anywhere from a moderately increased risk of that kidney disease advancing all the way to a very high risk. I also want to point out that UACR is very closely associated with the cardiovascular risk, what those cardiovascular outcomes that I spoke about earlier. So again, I just really want to reiterate the importance of having both of these tests and using that information together to truly evaluate the severity of the disease, the risk of progression. A couple of you also noted in the poll earlier that being unsure about how to talk about kidney disease to your patients was one of the reasons that you maybe one of your barriers to addressing it. And I definitely have heard that from a number of clinicians before, especially when many patients link kidney disease in their mind with kidney failure. And that, I would say, is another reason why having all of the information about kidney disease, both the eGFR and the UACR, is so important for being able to have these discussions. So you can really explain to a patient what these two labs mean and what does that really mean in terms of their risk of kidney failure and their risk of progression. So just really want to call out the importance of those two tests. And I emphasize the need for those two tests so much because we are doing a really poor job as a country of appropriately testing people for kidney disease. The data that's shown on this slide comes from a study that we did looking at data from a large national laboratory across the country. And we looked at what % of patients with either diabetes, hypertension, or both, as those are kind of the primary risk factors for kidney disease, and what % of those patients received eGFR and a UACR test in the last 12 months. And we looked at that over about a 5-year period. And you can see on this slide, the rate state by state, as well as the overall rate, was about 80% of patients did not receive those appropriate tests, or only about 20% did receive them. Patients who had both diabetes and hypertension were tested a little bit more frequently, as you can see in this orange box, compared to those that just had hypertension. But overall, we still have a lot of room for improvement here. And that guideline concordant screening is really one of the main barriers to having better diagnosis and better early management of kidney disease. We really could use a lot of help with that better early diagnosis and better management. This slide looks at results from a study done within an institution that really looked at quality of care amongst a large group of patients. And you can see from the image here and some of the data that some of the main things that we can be doing in terms of good quality of CKD care, like monitoring blood pressure and keeping blood pressure in a normal range, measuring blood sugar and keeping blood sugar control or A1C control under 7, using medications like ACE inhibitors and angiotensin receptor blockers and statins, which are all guideline concordant medications for managing CKD. And you can really see from these percentages that we aren't doing a great job meeting most of those objectives or guidelines. And over the course of the 8-year period that the study evaluated, we haven't seen real significant improvement in any of those outcomes. And I know this data is a little bit older now, but I will say even the current data that I'm seeing, that I've seen, is still pretty low. The most recent Healthy People data around ACE and ARB utilization in kidney disease, I believe, was sitting at about 50% of patients were who should be receiving an ACE or an ARB were receiving it. So what can you do about it? Taking a population health approach to managing CKD is something that NKF really recommends. And this flow chart, concept flow map, really outlines how you can do that. It really starts with understanding both the individual and the population level risk for kidney disease. And I'll speak a little bit later about some of the population health data tools that we make available to partners to help understand that population level risk, but also understanding the individual patient, their risk factors, and as you're planning for visits, doing some of that pre-visit care planning, identifying and flagging those patients that are at higher risk and do need that guideline concordant screening. Then obviously we need to screen for kidney disease. We need to apply that CKD diagnosis. As I alluded to earlier, about 80% of people that have some evidence of kidney disease in their medical record do not have a diagnosis applied. And then risk stratifying or staging that CKD, along with then treating that kidney disease. So ensuring that patients are having both the medication and lifestyle change information to manage that CKD risk and slow that progression. And again, for population level risk, we really, again, want to emphasize diabetes, hypertension, and cardiovascular disease. I've got on the slide here and also on the next slide some of the recommended recommendations for risk stratifying and managing treating CKD. This pyramid here kind of re-emphasizes some of those recommendations. And so it's really designed in a pyramid to kind of help you understand or see which therapies should be applied to all patients with kidney disease and which patients. Obviously, there's a lot of lifestyle change, things that you may already be thinking about for your patients with diabetes and hypertension, like healthy eating, adequate hydration, which we've already touched on being so important and so challenging in the farm worker population, good physical activity, smoking cessation, other healthy lifestyle choices is, of course, the best thing we can do all around to help to manage CKD, reduce that cardiovascular risk. And then there are therapeutics that are recommended for kidney disease, and these are kind of staggered based on the clinical indications around CKD and other concurrent diagnoses like diabetes and cardiovascular risk. I do want to call out that there are some therapies, some newer therapies noted on this slide, like the SGLT2 inhibitors, the NSMRAs, and the GLP-1 that are really game-changing when it comes to kidney disease in terms of reduction of that cardiovascular risk by as much as 30%. They also have been shown to reduce or slow that CKD progression. I do want to call out with some of those new therapeutics, we recognize that sometimes the cost of these medications might be out of reach for some of our patients. Some of our partners who we've worked with around quality improvement projects in kidney disease have found success in coverage of some of these newer medications through Medicaid programs, through 340B pharmacy waiver programs, as well as even discount programs from the pharmacies themselves. And I would also note that some of these medications are beginning to become available as generics. So we would recommend checking with your pharmacists and formularies to explore options for access to these therapeutics in your patients that have kidney disease. Lastly, I do just want to call out ACEs and ARBs as another medication to really emphasize. As I noted, we're doing a pretty poor job of ensuring that every patient with kidney disease is prescribed these medications. And unlike some of the newer therapeutics that I talked about, these ones are widely available as generics and generally very low in cost. So I'm not a clinician, so I'm not going to speak as much to some of the clinical information on here, but it describes the recommendations for when to use these medications and even addresses some of the misconceptions or misperceptions out there, especially I want to call it this one around recommendations include Black patients. We have heard from some clinicians perceptions that for some reason ACEs or ARBs are not recommended in that population, but that is not true. These are clinically recommended across race and ethnicity, and continuing on these medications until dialysis, and watching laboratory values when you're starting these medications. The serum creatinine may go up a little bit when starting an ACE or an ARB, but that does not necessarily mean worsening kidney function. It can be expected. So just monitoring those labs and continuing on. I would also recommend for those of you in a primary care space, building relationships and connections with nephrology peers to be able to help address some of these questions when you're starting to manage CKD. And so lastly, I want to kind of, before we get into some of NKF's tools and resources, and I want to be mindful of time, just calling out a really hopeful scenario and kind of a model that NKF really likes to point out. So we've done a lot about talking of the problems with kidney disease, the challenges of undertesting and underdiagnosis. But there are population health models, as I kind of articulated, that can be really impactful in improving CKD testing and management. And the Indian Health Service is a great example of that. And this slide kind of summarizes some of the work that they did. So over about a decade, IHS implemented a really focused population health strategy around testing for kidney disease in patients with diabetes and ensuring guideline concordant management. And through this intervention, they demonstrated a 54% reduction in the incidence of end-stage kidney disease during this population. So the reduction was very significant for this population, while other racial and ethnic groups continued to see their incidence of end-stage kidney disease rising. And I just want to highlight the text here. Although one might expect that such a dramatic increase or decrease in disease in this high-risk disadvantaged population be associated with novel and costly new therapies, medical interventions implemented by IHS were routine. A systematic population-based approach was instituted. Implement this evidence-based care was really what did this. So it's not about the complex, fancy new therapies. It's about taking a really focused and concerted effort to improve testing and improve basic management of kidney disease that can really have powerful outcomes. So I'm going to pause here for some other questions. I see some in the chat that I'm going to take a second to read. It looks like Kiara's maybe been answering some of them.
Caitlin, yeah, I think most of them have been answered. The two that are missing are, one, is our kidney stones a sign of kidney disease?
That is a great question. People who have frequent recurrent kidney stones, depending on the underlying cause of that could be something that could warrant additional follow-up testing. Kidney stones in and of themselves are not a risk factor for kidney disease, but in those patients that have recurrence or frequent cases of it, it is worth, from the clinicians I've talked to, it's worthwhile to assess their overall kidney function.
Thank you. And then lastly, the second one, what intervention works to help with urination when one has an enlarged prostate?
I am not a physician nor a pharmacist, so I am not sure about that one. I'm happy to bring it back to our chief medical officer to see if that's something that NKF has any information on, or if there's other physicians in this group that want to try to take a stab at that in the chat. I'd welcome them to do that.
Thank you. So I'll save that question and then we'll get back to everybody via email. What is the difference between CKD and CRF?
I am not sure what CRF stands for. Would that be chronic renal failure? Which might just be another name for end-stage kidney disease or kidney failure.
And just one more, sorry. Would
I see that one, yep.
Yeah, thank
you.
So
when an individual has ESRD and a fistula is placed, when is dialysis started and what lab results are looked at? Generally, I think that really varies on the patient in terms of when dialysis is started after a fistula is placed. Sometimes when people are under the care of a nephrologist early on with their kidney disease, that fistula is placed preemptively before the lab results indicate that that person needs to start on dialysis. So I think that's really going to be a case-by-case basis depending on the individual's lab results and what their nephrologist recommends. The lab results that are looked at to assess that need for dialysis and kidney function certainly would be the serum creatinine and the EGFR levels, as well as some other levels in the laboratory, the bone mineral metabolism levels like potassium and phosphorus may be looked at, as well as BUN and some other labs. And again, I'm not a nephrologist, but I'm happy to follow up with our chief medical officer to circle back on, a specific list of labs. But I think in my experience, it's been very case-by-case basis in terms of when that nephrologist feels dialysis is necessary to be started. All right, lots of great questions. I'm happy to hope that we're able to provide some help. So we talked a lot about the opportunities to improve testing, diagnosis, and adherence to guideline concordant care. And we've spoken a lot about population health models that can do that. We wanted to just take these next few minutes to kind of cover some of the resources that NKF has available to help clinics like yours start to implement some of these changes. The first thing that we have is something called the CKD Change Package, which is really foundational to all of NKF's. It really guides all of NKF's work in primary care and population health and improving CKD testing and diagnosis. It's a compilation of evidence-based and recommended strategies that have come from published literature, as well as from a group of over 20 clinicians that came together to help inform these best practices and recommendations. And so it outlines both how to best manage CKD in primary care, what sorts of population health tools, systems, and strategies should be put into place, as well as how to implement these types of population health programs in your health system or clinic. So starting all the way from understanding the data and building the case to bring to your leadership to say that this is something that we should be focusing on, all the way to how do you implement these clinical changes, how do you engage the care team, and how do you really manage chronic kidney disease. It's available freely online, both as a downloadable PDF as well as a web version that kind of guides you through each stage of change to really help tailor your experience in terms of where you need to go next. It's kind of like a cookbook for primary care is how I refer to it. We also have, as I noted, a population health data analysis strategy, which describes how to look at your patient data in the electronic health record or your claims data, or even working with your laboratory, whether it's internal or external, to look at the population level lab data to understand both the potential burden of undiagnosed kidney disease in your population, as well as understand how well you're doing with screening and testing for kidney disease in those at-risk groups. And for institutions that really are ready to implement a quality improvement initiative around CKD, but maybe they're not sure how to get started, NKF does have a structured learning collaborative program that we can facilitate to help your clinic walk through this process. And so if you'd be interested in learning more about any of these programs, I'd be more than happy to connect with you offline and share more details. In addition, we have a lot of freely available tools online for clinicians, EGFR calculators to calculate what that kidney function is, a CKD care algorithm that walks through how primary care clinicians should be testing for and managing their CKD patients, a teaching card that helps clinicians explain to patients how to understand those two laboratory results, the EGFR and the UACR, together and understand their risk of kidney disease. So again, for those of you who feel like, I don't know how to talk to my patients about this and how not to scare them, I can't say enough good things about our heat map teaching card, and there's also an associated video series that goes with it. And then all of our clinical guidelines are also available in an app. So all of these great online tools. I'm going to pass it over to Kira to talk a little bit more about some of our other tools.
Yeah, so it is imperative to provide needed support to the kidney community. And one way the NKF does this is through our development of tools and training to educate community health workers on chronic kidney disease. And in recent years, healthcare and society as a whole has had more attention on the role of community health workers as a trusted source to patients and a vital part of our healthcare system. And I do want to acknowledge we're using the term community health worker or CHW, but we understand that the role exists under many names, and we welcome all of those champions to engage in this program as well. So community health workers are experts at managing social determinants of health and can play a key role in raising awareness of chronic kidney disease risk factors and connecting people to proper testing, diagnosis, and care. And engaging community health workers is a critical path to ensure high-risk communities are not left behind. And so this initiative was created for community health workers and by community health workers, and the materials are written in plain language for CHWs to disseminate amongst their population. And it also offers certificate of completion for learners. And so we have a QR code here. Please feel free to scan the QR code to access more information about how the CHW Focus Initiative access and gain access to the 8 modules ranging from kidney disease basics, risk factors, impacts of social determinants of health, nutrition, kidney failure, treatment, and care options, as well as support tools like teach-back cards. And I'm happy to share in the year or so since this has been available, we've had over 300 learners complete at least one module. And at this point, I'll kind of pass it along to Amanda just to talk a little bit more about additional educational resources.
Thanks so much. So yeah, now I will just briefly go over the resources that we have for our patients and for our community members. The first being our Minute for Your Kidneys risk quiz. And so this is such a great tool to use that anyone can, in 60 seconds, efficiently, quickly assess their risk. So 5 to 8 questions, you go on, it's available in English and Spanish. And again, you get your results right away. You're able to put in your email address to receive results to your email, and then instantly be connected to additional resources. There's some great questions that are included that patients can take to their healthcare provider to gain additional information. So again, just a great efficient way to assess your risk, and it's available in both English and Spanish. And again, that's minuteforyourkidneys.org. We can go to the next slide. And another great educational tool we have are our flyers, right? We love our digital resources, but we know there is still a place for those printouts and hard copies. So of course, these can be accessed from from a device, but also printed out. And these two-sided flyers, available in a variety of languages, just take such great extensive information and are able to summarize it with some great visual aids, and just take that densely packed information and put it into a nice, nice summary in a 2-page flyer, front and back. So the codes there get you to the English and Spanish flyers. So some great handouts there that we have available. We can go to the next slide. And so this summarizes some of our key patient and community resources. So this is a great handout that we can provide after. This will be included. And so these codes get you to those signature resources: the Kidney Learning Center, Healthy Recipes, Peers Support, and NCFH Cares. And so our Peers program connects, patients who are, it connects you with that one-on-one support we can just keep it moving there. This will, all be sent out after, but that's a handout we can provide. And then NCFH Cares is a great tool. A great tool that connects you with a professional. It's a hotline. There's an email and phone option where patients and community members can be connected and have questions answered, one-on-one basis there. So this just dives a little bit. This gets you directly to that Kidney Learning Center. And so this offers a variety of educational topics ranging from the basics, kidney disease education, to treatment options, first steps to transplant, becoming a living donor, and even after transplant. So this is a great kind of self-paced video format where community members and patients can go on, choose their modules, and get that education at their own pace. And again, we're so excited that this is offered in both English and Spanish as well. And so that QR code takes you to the English, and then here is the Spanish site as well. And so all of those things that were just mentioned, we have this dedicated hub for our healthcare partners, our health professionals, so that those, Peers, Cares, Kidney Learning Center, all these great tools that we're able to provide to supplement and support the tools and things and the resources that you all are already giving to your patients. So this is that one-stop shop for all of those resources that were just mentioned, and again, can supplement the great work that you are all doing for your patients already. And now I think we will have our last poll of the day. So we just want to hear what resources you are most interested in. So we'll take a minute to launch that and get your feedback there.
While people are finishing this last poll, I do see a couple more questions in the chat, so I can start to answer those while people are filling in that information. There's a great question about social media and addressing challenges or misperceptions around, or I guess it's social media, like peer challenges and activities that might damage kidneys. I think that my best answer to this is, continue to try to reach young people with factual information, good resources around understanding their health and the functions of different organs in their body. And that NKF has a lot of great resources that explain the basics of how kidneys work, why they're important, things like that, that might be helpful to increase people's awareness and understanding of their kidney function and the importance of their kidneys. Do we want to share the results of that poll, and then we can finish up the Q&A? All right, so a great mix of requests here, but it does look like patient education materials is a clear favorite. So we will absolutely make sure that we follow up with those patient tools, as well as some of the clinician and quality improvement tools that we described as well. Again, all of these slides are going to be available after for you to access and use those QR codes. And that's a great segue into sharing our contact information.
I want to address one question that I'm seeing in the chat around nephrologist or urologist, which is the go-to specialist to get started with checking yourself for kidney disease. And so I would offer that checking for kidney disease is something that can happen under primary care, under a primary care visit, but if there's more advanced stage of kidney disease, then that will be a referral to nephrologist, and even more complications than nephrologist referral to urologist.